Greetings, Patho students, and welcome to 9. We're going to be covering kidney and urinary tract function and disorders of, which is chapter 24, 25, 26, 27. 24 is structure and function of the kidney. This is a review of your anatomy and physiology. Depending on how long ago, if you just took physiology last semester, you can just kind of breeze through this. And also depending on your individual retention of that content. Chapter 25 is an overview of disorders of renal function. Chapter 26, acute kidney injury and chronic kidney disease. That's the chapter I want you to deep dive into, chapter 26. Basically the difference between acute and chronic renal failure. And then chapter 27 is disorders of the bladder and urinary tract, and I'll go over what I want you to hit on that. This week also we have a case study due. The case study, oddly enough, is acute and chronic kidney disease. So that's another way to emphasize the most important content that I'd like you to cover this week. Let's get into that first chapter, chapter 24, the structure and function. Basically, it overviews the function of the kidneys. The path of blood flow through the kidneys is important. And that is demonstrated for you in figure 24-3, the path of blood flow through the kidneys. And then you have figure 24-4, which is a depiction of the nephron. So we call the nephrons, you have about 1 million in each kidney, the right and left. And we refer to the nephrons as the workhorse or the workhorses of the kidneys. That's where all the actual work is done. And then go on to review what the actual function of the kidneys are, which is filtration. You'll learn about glomerular filtration rate, or GFR. We refer to it as GFR for a good reason. It's hard to say glomerular filtration rate 3 times fast. But that GFR is of vital importance when we look at how do we assess the function of the kidneys and what diagnostics do we use. Many of our diagnostics are geared towards measuring the GFR, which again is a function of the efficiency of the kidney. There will be a mention here in this chapter of aldosterone. Recall aldosterone is one of my favorite adrenal cortex hormones. Aldosterone is what helps to regulate sodium, water, and potassium levels in the blood. There also is a mention to ADH, which we talked about previously in the section on endocrine disorders. ADH, antidiuretic hormone, which comes from the pituitary, which also regulates urine volume. Antidiuretic hormone. And then there also is a reference to that graphic, which I posted on Canvas weeks previous, that I said, please print this out. We'll refer to it again and again. It might have been introduced to you when we first looked at hypertension or cardiovascular disorders. It's the renin-angiotensin-aldosterone system and how that all works and affects the kidneys. And then, of course, how that is affected by disorders of the kidneys. So you'll recall again in this chapter, one of the purposes of the kidneys is to eliminate uric acid, urea, and of course, drugs. Medications. I previously mentioned the GFR and how important that is for us to evaluate the efficiency and the function of the kidneys. If there's 125 milliliters of what we call ultrafiltrate formed every minute, dependent on the flow through the kidneys, then you need to know that a normal urine excretion for a 24-hour period is about 1.5 liters. So we say normal urine per day is about 1.5 liters. So if you were to do the math on that 125 mLs of ultrafiltrate per minute through the kidneys, then you realize how much is actually reabsorbed into the body versus excreted. Please refer to table 24-1 for an overview of renal function tests. And you'll see that most of these are actually blood tests, with the two most prevalent being serum creatinine, and serum BUN. And you also see the normal levels for these tests. So when we say kidney function tests, BUN and creatinine should come to your mind first and foremost all the time. We don't have too many other tests that give us specific information about the performance of the kidneys, other than if we go to urine, it's a urinalysis or a collection of urine over a 24-hour period can also, that's actually how we do measure GFR. The other depiction of GFR that we look at is called an estimated GFR, and we do that through a blood test by looking at the ratio of the creatinine to the BUN. And I hear students call it BUN. People in medicine don't call it BUN. They call it BUN, which stands for blood urea nitrogen. So creatinine, serum creatinine, you need to know that creatinine is a byproduct of protein metabolism, as uric acid is as well. But that is really a constant, and the creatinine level is a direct correlation to your muscle mass. So your book might say that a normal creatinine level is between 0.6 and maybe 1.2. A good memory tool that I use to remember the correct creatinine level is simply 1.0. I believe your serum creatinine level and mine are likely to be 1.0, or maybe a tenth one way or another. And then BUN has a much broader range. Your book might say that a normal range for blood urea nitrogen is 8 to 20. That's milligrams per deciliter. So my memory tool for BUN is teens, that the BUN is usually in the teens, which is 10 to 20, and that will usually steer you in the right direction if you're taking a test or whatever, looking at some lab results and trying to make determinations. So again, urea, which is measured by the BUN, is formed in the liver. It's a byproduct of protein metabolism. However, where I say creatinine is static in general, in relationship to your muscle mass, how often or quickly does your muscle mass change? No, it really doesn't. It might change very slowly over time with age. Possibly, as we know, older people have less muscle mass, but BUN can change very quickly in relation to protein intake, in relation to your hydration status, and in some cases in relation to a disorder like a GI bleed or something. So if you have someone who's dehydrated, you could expect that their BUN would rise over what that normal teen number would be, where their creatinine might be still at 1. And so even though we use BUN and creatinine as a measure of kidney function, it's the BUN in a clinical setting that we really focus in on, because that is what we're trying to look at right now. What is the kidney function? You should look at the characteristics of normal, and like a normal urinalysis and an abnormal urinalysis. What's the significance of CAST? CASTS, basically that's protein or protein breakdown that is visible under microscopic evaluation of urine. And then specific gravity and osmolality has to do with, I sometimes say the thickness, but it really has to do with the amount of solutes that are contained in the urine. Just move on to then chapter 25, which is disorders of renal function, categories of disorders of renal function. First, we'll stop and look at genetics. I want you to look at one genetic disorder, which is the most prevalent of them all, which is polycystic kidney disease. So read a bit about that, and there's a graphic of that in the chapter as well. And then differentiate the mechanism involved in glomerular injury. There's two syndromes. One is nephritic, which is spelled with an I, and the other is nephrotic. So nephritic and nephrotic, you need to know those are not typos. Those are two separate disorders. Unfortunately, they have names that are very close to each other. Nephritic syndrome is an inflammatory process that damages the capillary walls. And here I am again talking about one of my favorite things, capillary wall permeability. If the capillary walls are damaged, they're not going to be able to contain that which they're meant to. And so things will spill out into circulation that should not be, or in this case, possibly spill out into urine, which is then a depiction of damage to the capillary wall. Nephritic syndrome most often follows a serious infection, and it is streptococcus, that Streptococcus aureus, that is usually the pathogen that causes such an infection. And then you'll read about Goodpasture syndrome, which is a form of nephritic syndrome. Then the other, nephrotic syndrome, there's actually a graphic of nephrotic syndrome, which is figure 25-8, a graphic of nephrotic syndrome. So here you'll see proteins in the urine, and this patient is left with an increased risk for infection because of one of the effects is a suppression of the immune system, and also an increased risk for thrombosis formation, so an increased risk for DVT, increased risk for pulmonary embolism, and other such terrible things. So some terms you should look at that relate to glomerular diseases of the kidneys are proteinuria, protein in the urine, hematuria, blood in the urine, pyuria, pyuria, oliguria, edema, hypertension, and azotemia, which is the presence of nitrogen wastes in the blood. Moving on to interstitial kidney disease, the two I'd like you to focus on out of many are acute pyelonephritis. That is acute pyelonephritis. That's a bacterial infection of the actual kidney. So the highest element of the urinary tract, the kidneys, usually again caused by E. coli. And then the nephropathy that's caused by drugs. So we often talk about medications as having a potential for nephrotoxicity. Unfortunately, many antibiotics have the potential for causing damage to the kidneys. I want you to look at figure 25-12, which actually talks about many of the causes of nephrotoxicity, one being age, one being hydration. So isn't it really sad if we're giving an antibiotic in a clinical setting, but we're failing to properly hydrate the patient, maybe prior or during or after that medication administration, and then we find out day 2, 3 post-medication administration that the patient has developed some possible acute kidney injury that could have been prevented if the patient was properly hydrated. Another cause, which this book doesn't refer to, but because I also teach pharmacology, if you think of the nephrotoxic effects of some medications, and also consider the dilution, the proper dilution of those medications prior to their administration or prior to their infusion, and also that goes along hand in hand with dilution is rate of infusion. We do know that manufacturers recommend a certain rate of infusion. If you are a practitioner and you fail to look up the proper rate of infusion, you could unintentionally or through your negligence be causing the patient to then suffer some nephrotoxic event because that medication was administered too rapidly. That is one cause of too rapid infusion of some medications. Others could be worse. For instance, vancomycin. I know this isn't a pharmacology course, but if vancomycin is infused too rapidly, it's an antibiotic, powerful antibiotic, which can cause kidney problems. If it's infused too rapidly, it can cause cardiac arrest. So isn't it worthwhile to as a practitioner, be your patient advocate, and at the very least, look up the medication you're giving so that you have adequate knowledge to give it safely, administer your medication safely. Then in this chapter, we move on to obstructive disorders of the kidneys. Obstruction. When you think of obstruction, very likely you're talking about the biggest category of obstruction is a stone. A stone in the kidneys, a stone in the ureters coming down from the kidneys, right or left, a stone in the bladder itself, or a stone in the urethra. So if you look at figure 25-3, it gives you some common causes and locations of urinary tract obstruction. The other term and disorder I want you to look at related to obstruction disorders is hydronephrosis. So when there is, let's say, a stone in the left ureter and urine is not allowed to pass from the kidneys down to the bladder because of that stone obstructing it, what's going to happen? Is the kidney going to stop making urine? No. Kidney doesn't know what's going on. So there's been a blockade in the exit strategy, let's say, of that left kidney. So what happens is there's going to be a buildup. It's called hydronephrosis, and it can be picked up on it can be picked up on x-ray, but also on other imaging like a CAT scan, where the kidney just basically starts to get bigger and bigger as there's a plumbing obstruction. So you can imagine what that backup causes. And then, of course, the associated pain that the patient is starting to experience. So I do want you to look at how do we diagnose and how do we treat kidney stones. Then going on to tumors, which is our last stop in this overall view of disorders of the kidneys. Two things. One is Wilms tumor. Wilms tumor is considered a pediatric finding, or a pediatric tumor, usually found in children between the ages of, I think, between 2 and 5. So read a little bit about Wilms tumor, which is WILMS, and that pediatric onset. And the other is an overall view of adult kidney cancer. What is the incidence? And you may not realize it, but smoking is a risk factor for kidney cancer. Okay, now moving on to chapter 26. This is where I want you to deep dive. Acute kidney injury and chronic renal disease. Two separate disorders. This kind of slapped me right in the face when I had a student complaining that it was a bridge student, so an advanced placement student I had as a paramedic. And now this person was in block 3. And I'm saying, well, how's it going in block 3? How are you finding the content? And he goes, it's fine, except they're teaching kidney disease backwards. They're teaching chronic first before they teach acute. At which time I said, time out, let's review. Two separate disorders. Even though we think of acute of something sometimes turning into chronic something, please know that when it comes to kidney disease, maybe that's the reason they've changed it. It used to be called acute kidney disease. Now they call it acute kidney injury. And the word injury kind of gives you the idea that there could be some recovery. And certainly in acute kidney injury, that's what we're hoping for. We're hoping for total recovery. So the mechanism of injury for acute kidney injury is a multitude of things, but they all involve one common factor, which is hypoperfusion of the kidneys. So some event has happened, either trauma or shock or sepsis or severe dehydration, where the kidney is being hypoperfused. The kidney itself as an organ is not getting sufficient circulation to do its job. Those little nephrons, those little workhorses are just kind of laying down sideways and not able to produce urine and then obviously do the filtration and the other functions of the kidneys. It generally has a sudden onset, as I say, following one of these acute incidences. There is some discussion about pre-renal, post-renal, and intrinsic acute renal failure, which basically has to do with not the stages of acute renal failure, but the location of the problem. And so read a little bit about this. Don't get too excited and just rely back on common sense and your terminology. So if we say this patient has pre-renal acute kidney injury, pre-renal means before the kidneys. So something has happened on its way to the kidneys, like a renal artery occlusion, for instance, which is going to prevent blood supply to the kidneys. There's nothing wrong with the kidneys or the urinary tract, but there's insufficient blood coming into the kidneys. So that would be an example of pre-renal. The other is intrinsic acute injury, which can be some of these diseases that we've talked about previously, which can actually cause some damage. And the other is post-renal. So that is after the kidneys. So remember when we were just talking about a stone that's causing problems. So the kidney is starting out healthy, the nephrons are all doing their job, but there's something happening after the kidneys that is preventing the flow of urine that could eventually result in acute kidney injury. So the pre, the intrinsic, and the post has to do with the location of the problem that's causing acute kidney injury. Those causes you can see in figure 26-1 has a nice chart about the causes. Much more prevalent is, new disorder now, chronic kidney disease, CKD, chronic kidney disease. The most common causes of chronic kidney disease is diabetes and hypertension. That's number 1 and number 2 on a list of maybe 5 or 6. How we define chronic kidney disease is over a period of 3 months where the GFR has fallen below 90 mLs per minute. So let's say that gets diagnosed in November, the patient comes back in 3 months for another evaluation. If their GFR is still low, then we're going to say, I'm very sorry, you have chronic kidney disease. And the reason we say we're very sorry is that chronic kidney disease is irreversible. Patients can live for many years with chronic kidney disease, and we'll also talk in this chapter about the treatment options for it. There is medication that may or may not be helpful in the early stages. There is dialysis, there is kidney transplant, and of course, in the early stages, there is dietary modifications that can actually assist in slowing the progression of chronic kidney disease, and that's what we try to do, is slow its progression. So please refer to table 26-1 to review the stages of progression of chronic kidney disease, and know that we're talking about 2 separate and distinct disorders. If I have to have one, I'll take the acute, although the way I would get acute chronic injury would be probably pretty unpleasant, like if I had sepsis or if I was involved in a traumatic event. However, if I receive good medical care, there's every indication that I should recover from acute kidney injury, where chronic is irreversible. Let's move on to chapter 27, disorders of the bladder and the lower urinary tract. Here I want you to, you'll see some graphics that remind you what the lower urinary tract involves. In this chapter, I want you to make the connection of the neurological system and control of the bladder, or your ability to urinate at will, versus being incontinent, which is another disorder that is overviewed in this chapter. Bladder incontinence is a huge deal, but know that even though elderly are more at risk for bladder incontinence, that bladder incontinence is not a normal part of aging. there's always a cause for bladder incontinence, and the cause will not be because you're old. It will be because of loss of some reflex or suppression of some neurological function, or in, the worst cases, like someone's had a stroke, and because of the neurological damage, they lose control of their bladder, etc. But I do want you to pay attention to, I believe it's table 27-2, which talks about the causes of, say, neurogenic bladder. So you could have an overactive neurogenic bladder or an areflexic bladder, which is not getting any signals from the neurosystem at all. So read about that. And then, of course, the incidence of incontinence in the elderly population. And then lastly in this chapter is the diagnosis and treatment of urinary tract infections, or what we call UTIs. UTIs can affect children, adults, and elderly. They are very prevalent in the elderly, and there's a number of reasons why. Some of it has to do with lack of hydration. They are also more prevalent in females, I would say, and you're going to read about why that is, but I would say off the top of my head it is because the urethra, obviously, in a female is shorter. And so there's a shorter distance for, again, these are caused by E. coli, that E. coli to travel up the urethra into the bladder. There's a phenomenon called the washout effect, and you should be familiar with what exactly that is. And then finally, the incidence of bladder cancer. In the previous chapter, we talked about the incidence of renal cancer or kidney cancer. This chapter focuses on, at the end of the chapter, on bladder cancer. Again, some of the same causes that predispose someone to renal cancer also affect their risk for bladder cancer. And that is week 7. Again, don't forget you have a case study. It's case study number 3 on acute kidney injury and chronic kidney disease. And that will help to reinforce some of the new learning that we have in this week related to that very important chapter 26. Thank you. Have a great week.